Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
This is Lindsay Smith Rogers. Today, why methadone, a gold star treatment for opioid use disorder, is so hard to get. Dr. Brian Hurley, president of the American Society of Addiction Medicine, talks about what the organization and others are doing to try and change federal regulations around this life-saving medication. Let's listen. Dr. Brian Hurley, thank you so much today for being on Public Health on Call. How are you?
Very well. Thank you for having me.
Sure. So today we're going to talk about methadone. There are a lot of people that need it, not a lot of people that can get it. So first of all, let's talk about why methadone.
Methadone is a really effective medication to treat opioid use disorder. It's one of the three medications that are FDA approved, the other two being buprenorphine and then naltrexone. Methadone has an advantage being able to start a patient on methadone treatment even before they're in withdrawal. Based on their clinical exam, you can start somebody on a lower dose of methadone and then titrate up over the course of the patient's first few weeks in treatment.
And tell me, is it effective?
Yes, methadone is an effective medication to treat opioid use disorder. It reduces opioid use. It supports patient retention, or basically it supports people continuing in treatment. And for patients that have opioid use disorder with other drugs, actually the use of other drugs oftentimes goes down as well as part of their methadone treatment.
So we have an opioid epidemic. We have a lot of people that could benefit from this medication. Tell me a little bit about why it's not readily available.
Methadone was first developed in the 1960s as a treatment for opioid use disorder. And the initial regulations around opioid use disorder, when it's launched in the 1970s, created a network of opioid treatment programs as federally licensed locations. And the only way to get methadone outside of a hospital would be to go to one of these federally licensed locations and pick up methadone from these spots. And one of the challenges with the current regulation of methadone being specific to opioid treatment programs is we don't currently have enough opioid treatment programs spread in enough locations. And it limits access to methadone because if you can only get it from these federally licensed locations and there's not enough of those locations, then it essentially becomes a supply issue.
So you're saying that these policies have been in place since the 70s, but things have changed considerably since then. So why do we still have these regulations and why are they so intense?
The regulations around methadone, but I would say addiction treatment in general, addiction has been one of the most regulated areas of American healthcare. I think part of that has to do with stigma around people that use drugs. Part of that has to do with the oftentimes not complete understanding of which systems are the best place for people with substance use. Is it criminal carceral systems? Is it health systems? Now, as the president of ASAM, the American Society of Addiction Medicine, we feel strongly that health systems are the system for people with substance use disorders to receive treatment. And part of our strategic priorities is to limit criminal and carceral system interference. Now, OTPs were built in an era where there was an assumption that unless you have a lot of rules, things could and would invariably go wrong. What we've seen with, say, buprenorphine is the ability to treat larger numbers of people outside of federally regulated settings successfully with buprenorphine. And there are models, right, research models, where the same can be done with methadone with well-trained physicians and other clinicians, right? So a well-trained workforce can manage methadone outside of OTPs. There's examples from other countries and even, again, research examples here, but our regulations really haven't caught up to the science.
And I do want to just clarify a point. Can you tell us a little bit about the difference between methadone and buprenorphine?
Yes. So methadone is a slower acting compared to other opioids. It doesn't absorb as fast as other opioids do, and very long acting opioid. So what happens when somebody is taking, say, heroin or more recently, fentanyl? Those are very fast-acting, but also short-acting opioids. So you're on this roller coaster of intoxicated with heroin or fentanyl, and then very quickly in withdrawal a few hours later, and then up and down, where somebody needs to use essentially throughout the day in order to avoid withdrawal. Methadone has a significant advantage of being long-acting. So you take a dose, say in the morning, and it lasts actually until the next day. So people don't experience withdrawal the same way. And it also supports opiate tolerance, which might sound like an odd thing to be helpful. But one of the big causes of overdose is respiratory arrest. People stop breathing if they take too much opioids. But if you keep somebody's opioid tolerance up, it actually lowers the risk that somebody's going to overdose and die. And when people have this persistent opioid tolerance, interestingly, people can still function, go about their day, work. I mean, people really do get their lives back with methadone treatment. The difference between methadone and buprenorphine is buprenorphine, unlike methadone, actually blocks other opioids from binding to the receptor. So if you take buprenorphine before, say, the heroin or the oxycodone or the fentanyl or whatever the short-acting opioid is, if you take buprenorphine before that has really had a chance to metabolize out of your system, it can precipitate withdrawal because buprenorphine blocks other opioids from binding. You don't get that precipitated withdrawal with methadone. The other thing that makes buprenorphine and methadone different is buprenorphine doesn't have a what's called full opioid effect. It's what's called a partial agonist. It has an opioid effect, but not as strong as a full agonist opioid. And so it's very hard to overdose on buprenorphine, right? Buprenorphine on its own actually is a remarkably safe opioid. Methadone you can overdose on if you take too much of it. And so that's why it's important, if you're going to treat people with methadone, to know what you're doing, to understand where somebody's opiate tolerance is, to make an appropriate selection of the first dose, and to make an appropriate titration, which might be very fast for people with a high opiate tolerance. It might be very slow without, and it's up to the clinical judgment of the team to understand that titration schedule.
And so is the understanding that with both of these, I mean, you mentioned that during this time, this is a time when people can be managing their dependence and, as you said, getting their lives back together, going to school, going to work, doing what they need to do. What is the goal of methadone treatment?
The primary goal of methadone treatment is to keep people alive. And that's the true of almost every treatment, is keep people alive. So number one, reduce overdose risk. Number two, keep people engaged in treatment, right? Treatment retention. Number three, reduced opioid use, ideally. We're looking for people to not necessarily be within the context of their active substance use. So we'd like this to support people changing their substance use. And then we also want to make sure it's tolerable, right? The goal of treatment is that people aren't having terrible side effects. They're not nodding off all day. They're not constipated, right? So we want to balance those things. One, keep people alive. That's priority number one. Two, keep people showing up. Three, ideally support people in achieving their goals with substance use, and then do so in a way that's manageable from a side effect perspective.
So we have this incredibly effective medication. It's been proven. We've got a lot of regulations around how to actually get it, which is problematic. And there's a lot of need for it. So why can't we just change the regulations?
The current federal statute is specific around methadone being dispensed from OTPs. Now, there's a bill that would modify that statute to create a pathway for additional regulations, but we would need the law itself to be rewritten and amended in order to update the regulations. And as it happens, there is a bill called the Modernizing Opiate Treatment Access Act, or Mota, which, if adopted, would create a pathway for board-certified addiction physicians working in partnership with community pharmacies to manage methadone treatment for opioid use disorder outside of the OTP network.
Why wouldn't something like that pass? Where's the pushback on this?
There is not broad understanding around methadone. And oftentimes, because methadone is so regulated, there might be assumptions that methadone isn't safe. What I've heard is that there are people that I know that are concerned around the safety of methadone. I will also say I've traveled to other countries that manage methadone out of community pharmacies and out of generalist practices. So I've seen examples where it can be done with appropriate training. But I think that there is a lot of stigma around this medication, and that can be difficult to overcome even with good evidence.
Tell me about the current methadone treatment centers, like where people can go to get methadone. What would have to change in order for this to be made more readily available?
So Mota, the Modernizing Opiate Treatment Access Act, would not actually change anything fundamentally with respect to opiate treatment programs. They would continue to be able to provide the life-saving services that opiate treatment programs provide. And let me be clear, I'm supportive of OTPs and OTP services. I think that they do life-saving work. They're just not operating at scale. And we need, in the worst overdose crisis in American history, a pathway to be able to scale responsibly. So the Modernizing Opiate Treatment Access Act gives us a pathway forward. There are already a whole network of board-certified addiction physicians, and there's a very extensive network of pharmacies across the United States. What Mota would do is create an additional pathway that could be scaled using existing infrastructure. That's essentially the shift, is it would create additional pathways to methadone. It doesn't replace OTPs. It doesn't obstruct OTPs. It doesn't actually change the opiate treatment program business. But what it does do is create an additional pathway for patients that are in need of this vitally important treatment.
And you mentioned stigma several times. First, like you said, the fact that it is so highly regulated just gives off the appearance that there's something maybe dangerous or criminal or evil about this in some way. But really, it sounds like you're saying this might be similar to not allowing a doctor to prescribe like medication for heart disease or diabetes. Is that accurate?
Yes. And in fact, a lot of the arguments around eliminating the registration requirement to prescribe buprenorphine were rooted in that very same idea that physicians in medical practice can prescribe a whole host of things, including things that are very toxic. You can kill people with insulin, for example. But we have protocols that people follow to keep them alive despite insulin treatment. But we don't regulate insulin with a separate registration requirement, right? But we do with buprenorphine. And a lot of that is the stigma around people with opioid use disorder and an assumption, I think, of criminality. And that if you don't have a lot of rules, then something bad might happen. And the truth is, I think the saner heads have prevailed. We've eliminated the separate registration requirement. We are in the midst of really establishing the mainstreaming of medications for opioid use disorder. Now, what we're not saying with the Modernizing Opiate Treatment Access Act is that everyone can prescribe methadone for anyone at any time, anywhere. That's not what that law would do. But it would be a responsible extension of the current rules to allow physician specialists that prescribing authority. So on one hand, yes, we want widespread availability of addiction medications. We recognize that methadone is not without risks, just like all medications are not without risks. And that the next step in methadone regulations is this extension of methadone management to train physician specialists.
So tell us what is going to happen next. What can we hope to see with Mota and when?
Well, I would love to tell you that Mota is on its way to the president's desk to be signed. We are not yet there. So we are currently working with our legislative partners, making sure there's broad awareness of the need for opiate agonist pharmacotherapy, particularly methadone treatment in the context of the worst overdose crisis in American history. We need all hands on deck. We need methadone, we need buprenorphine, we need naltrexone, we need all of the medications that work to treat opioid use disorder available to patients. And we need to vest trained physicians in our health system with the ability to bring these treatments to patients responsibly.
Well, Dr. Hurley, thank you so much for the work that you're doing with the American Society of Addiction Medicine. Thank you so much for pushing this forward and for really helping to destigmatize this life-saving medication.
Thank you so much.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith Rogers, and Stephanie Desmond. Audio production by J.B. Arbogast, Holly Cardinale, Philip Porter, Spencer Greer, and Matthew Martin, with support from Chip Hickey. Distribution by Nick Moran. Production support from Catherine Ricardo. Social media run by Grace Fernandez and Shian Briscoe. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.